Oh.
Hello.
Hello, Mansoor. Mansoor, Shehzad is going first. Hello.
Hello.
I can hear you, Mansoor. Assalamu alaikum.
Mansoor, do you want to go first?
Yeah, I kind of hear you now.
Okay, no, I think Shehzad is going first, so you can have your presentation afterwards, yeah? Okay, so good morning, good afternoon, good evening. Welcome to DOW 2002 CPD Webinar series. A very warm welcome to all of you. Today we have two very special guests, our classmates joining us, one from USA, another from Canada and from Pakistan. So the first speaker is Dr. Shehzad Shamim, who is a consultant neurosurgeon and an associate professor at Aga Khan University Hospital. And he's going to be speaking about the philosophy of healthcare. So Shehzad, over to you.
Okay, thank you very much, Naseem. So firstly, I would like to make a correction here. My topic today is not going to be the philosophy of expensive healthcare, but it's going to be the use of technology in healthcare. And I'm also going to talk a little bit about impact on cost versus outcomes. I have a couple of disclosures. Firstly, a segment of this talk has been delivered as part of a psychology course at IBA, and this was centered on quest for the post-human, which I later understood it was actually transhuman, and the ethics of technology in healthcare. So a lot of what I'm going to talk about is actually based on this thesis, the quest for achieving the transhuman and the ethics of technology and in healthcare. Also, I have to disclose that I work in a hospital which is widely accused to be the most expensive in the country. Okay, so this is the logo that not a lot of us will be familiar with. And I'm sorry, Naseem, is that okay that we take questions in the middle, or do we have to wait till the end?
I think till the end, Shehzad.
Yeah, you carry on. We'll take questions in the end.
Sure. So this logo actually represents a society which focuses on transhumanism. So a philosophical society which is based on the different aspects of achieving the transhuman. So what is a transhuman? In a sense, a transhuman is a state where you are able to improve the human body and the human mind with the help of technology. And so it's not just the body, but also the mind. And in it encompasses all sorts of artificial intelligence, machine learning softwares, and the bionic arm, which you see here. So it's not this Sophia, the robot that it is on all WhatsApp groups, on all Facebook pages. It's not just the bionic arm, which does not improve a general human body, but actually covers a deficiency. So a transhuman is essentially something which improves the existing human body. So this picture on the right, which is basically a patient with a long segment fixation of the thoracic spine. So there was nothing wrong with the patient in the sense that there was nothing missing from the human body, but the screws actually improve the functioning of that human body. So this is, in a way, what transhuman means. This is a picture of my operating room. The LCD screen that you see here, just 3 of the 5 that I have installed. On the left, you see my operating microscope and my neuronavigation, and this arm on the hanging from the ceiling is a robotic arm. So my operating room costs around $2.5 to $3 million. And it's important that I mention it here because the rest of the presentation is basically dealing with this. So the idea for choosing this topic is partly to do with my specialty, because it is an expensive specialty. And it's also very expensive to have neurosurgical problems treated, not just in Pakistan, but all around the world. But living in a country like Pakistan, where it hurts more to the patient, to spend this much money, for what we feel is an essential medical requirement, it actually makes you think this way. So this is a hybrid OR which we are aiming to achieve, and we should be able to get most of this equipment by the end of next year.
Inshallah.
We use the very high fidelity operating microscope, which gives us very high precision, and the equipment that I have in my OR is the state of art. So there are hardly any ORs around the world which are better equipped than my ORs. The software that you see over here, the image that you see is from a software called Neuronavigation. What it essentially does is it allows real-time navigation to the brain intraoperatively. So while we're operating on tumors, we can actually see where we are on the MRI scanner on the software. And we're now able to use the DTI software. So for my non-neurological friends, DTI is Diffusion Tensor Imaging, which actually shows you all the white matter tracks, which going down from the cortex through the basal ganglia down to the brainstem. And we're able to track these softwares, these images intraoperatively. So we're able to plan our surgical dissections based on the DTI software and based on the patient's own white matter tracks. And at the end of the day, all this leads to safer and better surgical outcomes. Now, this sounds very fancy and it's also very nice to use, but for most of the tumors that we do, this isn't useful at all. So what you see here is a pituitary adenoma pre and post-op images, both for my patient. For this kind of an operation, which makes the bulk of our brain tumor cases, this software and all of this expensive stuff is not used at all. Similarly, this brain tumor, it's a meningioma, again in a young patient, and this is a post-op image. Both of these patients are now 4 years down the road without recurrences. So for cases like this, all of this software is basically useless. And all you need is a good microscope, a good anesthetist, and some microvascular instruments to do this kind of surgeries. Where the software is useful are cases like this. This is an intraaxial tumor, it's a glioma of the right frontal lobe. And for cases like this software actually improves your surgical dissection. So if you didn't have this software or this equipment, maybe you would be able to take 80% of this tumor out. But with all of this equipment, so with all the $2.5 million investment, I'm now able to take the entire tumor out. And in fact, I can also combine it with the patient awake. So I can take a little margin of the tumor out without damaging the patient at all. So you would think that this kind of investment actually improves patients' outcome. We're taking entire tumors out, which we were not able to do before. But if you look at the outcomes of these glioma patients, sadly, despite better surgical results, the outcomes haven't changed. And even though better surgical results is the only thing that has made a difference, but despite of that, over the last few decades, we haven't been able to make much of a difference in brain tumor outcomes for these kind of tumors. And if you look at this slide, and in the last 30 years, all we've been able to achieve for intraaxial brain tumors is maybe a couple of weeks advance in survival, which isn't saying a lot. But if you look at the research that has gone into tumor surgeries like this, it's more than $1 trillion already. And that's only North American research. Now, this is again one of the kind of cases that we do routinely. It's an extended pedicle screw fixation for thoracolumbar spine. And again, these kind of, since surgical implantations has become so safe now, we've noticed an increased surge in using these implants. And again, an occipital cervical thoracic fusion for a patient with an unstable spine. Before these implants were so commonly used, we were still managing these patients. And if you look at the outcomes before the start of using these implants and after the start of using implants, you don't see a huge lot of difference. Of course, the outcome measures have changed, and now we're not using the same measures anymore. So it's possibly impossible, well, possibly inappropriate to measure the two eras. But by and large, the general outcomes that we all aim to achieve have remained the same. So what's the point of putting all these implants? Again, this is a cervical disc replacement. It's a $15,000 replacement structure that you can get imported from anywhere. There are many companies making it, mostly from North America, but also German, French, and Italian companies. Each cervical disc costs around $15,000. So in this patient, we have $45,000 worth of disc. The selling point of these artificial discs was that with these discs in place, you won't have to fuse the spine. So this was, in a way, offering a better surgical options for patients with degenerative disc disease. But 6 months down the road, we now know, and this is despite all the FDA clearances, all the animal researches, we now know that human body, all of these artificial discs eventually fuse. So again, the advantage of using these implants, we now know is no longer there. And despite that, if you look at the use of these implants, and these are thousands of operations, and the data is quite old now, but this is essentially North American data. We're using more and more and more of these implants, especially since these became FDA approved and the insurance companies started to reimburse them. The rate of usage of these implants has increased significantly. And it's interesting that if you look at the literature, the use of implants, so you would assume that using expensive implants, subjecting a patient to an increase and a longer surgical time would mean that these implants are useful. And but even if you look at international data, for the same expertise of surgeons, the use of implants varies significantly from country to country. Not just that. So in NHS, where the surgeons don't get reimbursed for using these implants, they tend to use less and less of these implants as compared to North American surgery. Even in North America, the utilization of these implants differs significantly from hospital to hospital and according to which insurance company that you're dealing with. So patients with certain insurance companies which reimburse better tend to have patients who get more of these implants. And I know Naseem is here, who's a stroke specialist, but for most of the stroke patients that we investigate, and strokes investigation is quite expensive. The MRI that we're doing here costs around 50,000 rupees, and it's probably the cheapest MRI scan in the world on a 3D MRI scanner, but still quite expensive. And yet, for a large majority of patients, these expensive MRI scanners don't give you any edge in terms of how to manage these patients. Here's another example: spinal cord injury. And it's one of the most expensive ailments to manage anywhere in the world. It's one of the most expensive ailments to manage. These are usually young patients, male patients who have a longer life expectancy, and the cost of managing these patients is immense. Not just that, but the surgical treatment of these ailments is also very expensive. However, there are piles and piles of literature which shows that surgical intervention does not actually improve outcomes. But despite of that, every single recommendation, every single guideline ensures that any patient with any amount of injury, any degree of instability gets surgical intervention, gets surgical fixation. A few more examples: head injury. We all know head injury has a very poor outcome. Over the years, more than $1 trillion have been invested into trying to improve outcomes from head injury. We've had randomized controlled trials on all sorts of stuff. We're now even trying anti-cholesterol medications, calcium channel blockers, steroids, you name it. But so far, the only thing that, I must also mention the use of ICP monitors. We're now using ICP monitors for most of our head injured patients, and it's become a standard of care in advanced centers for managing head trauma patients. And despite all of that, neither the ICP monitoring nor any of these interventions have actually been shown to improve outcomes from head injury. In fact, the single most important intervention which has improved outcomes from road traffic accidents has been a helmet, which costs around 200 rupees. Now, the relevance of this is even more in a country like Pakistan, where more than 80% of our patients, our clients, are out-of-pocket payers. But not just in Pakistan, even in North America, for example, the cost of healthcare or the cost of managing these patients is increasing exponentially high, even if you compare to GDP or their wages. Now, we all know that the health outcomes are better in patients with better GDP. So there's a direct correlation between GDP and health outcomes. And the only outlier is North America, which, despite having the world's largest GDP, the health outcomes are in the mid-20s when you come to international ratings. But not just that, even if you look at societies, even if you look at countries, the health outcomes are also related to a patient, to how much a patient can afford. As a matter of fact, if you go on the WHO website, in the list of indicators for better health outcomes, they not only mention your per capita income, but also your social status in the society. So it's not just if you can afford better healthcare that ensures that you have better outcomes, but also what's your social standing in the society, which also affects your health outcomes. In fact, there's now so much literature on this, and it's sad, but it's true that a rich person living in Sudan can have the same health outcomes, actually have better health outcomes than a poor person in the middle of Baltimore. And this is Pakistan's health expenditure to GDP ratio. So where in other countries are increasing their health expenditure as compared to the GDP, Pakistan inversely is actually decreasing its health expenditure compared to GDP. So now consider that in a country which is already comprises of 80% of out-of-pocket payers, there's hardly any insurance, and where also the government is reducing its expenditure on health. How is it justified to use all of these expensive modalities in a country like this? So, in a way, I'm accused here of this because I spent millions of dollars every couple of years in making my budget, in trying to get these expensive stuff in my OR and my wards and my ICUs to make my hospital state of art. So why do we use it? Why do we use expensive technology in providing health for patients when it doesn't make so much of a difference for majority of our patients? Well, I spoke to people around me. Especially spoke to spine surgeons and brain tumor surgeons. Why are they compelled to use all of this technology? So using this expensive OR not just increases the cost of that particular patient who needs this technology, but also increases the cost for all the other patients who actually don't require all this equipment. I think this answer, that maybe innovation, since innovation is supposed to distinguish between a leader and a follower, the more you innovate, the more you acquire this cutting edge. Maybe that's the way to remain healthcare leaders. Somebody gave me this example that this is in a way justifiable because you're actually trying to find a better way to help your patients. But the justification that I found most appropriate was this one. And this comes from a North American entrepreneur, that the difference between men and boys is the price of their toys. And I mean, if I ask myself why I use this equipment, well, one answer is that I like using this equipment because it's fancy. It makes my work more exciting. It also makes my work easier, but it allows me to show off more. It allows me to go to meetings and show my MRIs, post-op MRI scans, and tell them about my OR. So what is the cost of this technology to the society, to our patients, what is the cost that we are willing to give for this innovation? Well, there's always a pressure to use the best available tools. And the pressure is not just from our So the pressure is not just from our hospitals, but also from our patients, from our insurance providers, from our peers, because there is an assumption that if you have more expensive equipment, if you have more high-end stuff in your service, you're probably providing better care, or at least you're providing care as well as any first world country. But when we do acquire all of this, there's also an element of human learning curve. Now we all go through workshops to be able to use this stuff safely, but despite of that, every time any new technology is introduced, especially in the operating rooms, it increases the operating time, it increases the cost of care. There is some element of a learning curve, so maybe it does not jeopardize patient safety, but it does increase the operating time, and in a way that puts the patient's safety in question. But at the same time, as I said, it does not only increase the cost of that particular patient, but it also increases the cost of the rest of the patients coming to your service. And then there's a pressure from the institution that you've invested so much money in this stuff, so you have to use it more often. And that's the time when your indications start becoming more gray. So you're starting to use this equipment in patients who probably don't need this equipment. And this is just not my opinion. This is what we openly talk about in scientific meetings. but that's something that we can't publish. We can't tell our patients. And then with increasing cost, with increasing investments, there's increasing expectations. And when those expectations are not fulfilled, there's increasing disappointments. But we keep on repeating the cycle. There's always pressure to do more. There's always pressure to do as well as anywhere else. So there's always a struggle to create the transhuman. And this is a particularly interesting graph. It's the hype cycle. And our software engineers are very familiar with this. So let me take you through this. So whenever a new technology or a new app or a new software or a new machine is introduced in any group of professionals, initially there's a huge hype. So it starts with an innovation trigger, and then there's a huge hype around it, and then there's this zone of peak of inflated expectations. So you expect that now that you have that machine, the whole world is going to change. And this is usually followed by a trough of disillusionment. So you realize, well, I made the investment, but actually it's not as good as what it's promised to be. And it's only the good investments stand the test of time till here. After that, there's a slope of enlightenment. That's what they call it. That's when you realize which stuff to keep using, which stuff to stop using. And finally, productivity, wherein stuff which actually works stays on the shelf, the rest just fades away. But all of this takes more than 10 years. So a lot of expensive, unnecessary machinery that we are buying today, which may be completely useless, will stay with us, will stay within the system for at least 10 years. And that's the time that the enterprises require to get back their investments. So it works well for the businessman, it works well for the entrepreneurs, and it maybe works well for the surgeon who likes to show off, but it does not work that well for the patients. And I'm going to give you one last example. I know I've already given too many examples. Use of endoscope in spine surgeries. So I have the honor of being the first spine surgeon to start endoscopy in Pakistan. We initially invited a master trainer. We had a workshop. We invited people from all over the country. We did endoscopic surgeries in dozens and dozens of patients. And 2 years later, evidence started coming that it actually does not make any difference in outcomes. So for the past 8 years, I have not done a single endoscopic surgery. Despite of that, just last year, there was a big spine meeting in Lahore. In fact, it was the biggest spine meeting of the country, and I was asked to chair that meeting. The topic of the entire 2-day meeting was use of endoscopy in spine surgeries. And despite being the chair of that meeting, in every session, I used to disclose that I don't use the endoscope anymore because the evidence does not support it. Having said that, the sales of endoscopes for spine is at its all-time high. So now the centers in Pakistan, there are at least 20 centers who have spine endoscopes.
Passive positive therapy.
Some of those centers don't have ICUs, don't have ventilators, but they're willing to spend money on the endoscopes rather than ventilators. So that's the kind of race that we're all in. So I'm going to skip a couple of these slides. This is, well, I might as well. Most of you will know the story about the Luddites. So these were in early 19th century Britishers who thought that the technology will take away their jobs. So they started burning stuff. They started burning textile industries. They started harassing people. Now, I'm not a Luddite. I'm not against technology. In fact, as I said, I really, really enjoy technologies. I'm one of those boys who like expensive toys. But on the other extreme are people who are using technology for, claiming to achieve which is impossible. But that's not the sad reality. The sad reality is that people are willing to buy it. So with this, I'm going to end my presentation. I hope I was on time.
Yes, thank you very much, Azad. Excellent presentation. I'm sure all of us benefited from it. So Mazhar, over to you. Our next speaker is Mazhar Mirza, and he's a sociologist, philanthropist, positivity guru, author of books. So Mazhar is going to talk about a very, very important topic, anxiety, depression, and the role of positivity and passive therapy and all those things. So Mazhar, over to you.
Okay, am I getting through?
Yes, we can hear you. Yeah.
Okay, let me start by telling you guys that uh, for all the people that are alive on the planet, if we compare to, is more than the people who have already died in the planet. I'm coming to the medical field after 15 years, so I might be giddy, so don't mind it. And nothing compared to what Shahzad made. Okay, so, kya kare? Okay, so another thing I would like to say that like the sunlight that we get, right? 2 minutes of sunlight's energy is equal to 1 year of all the energy that we use as human beings, may it be automobiles, air conditioners, anything that we might use. So the point is that a lot of things that we have that are already present around us, we might not know them. Okay, so that's why those things are not actually, we cannot integrate them into our lives, right? So I just started this concept. I call it passive positive therapy. So what is passive positive therapy? Passive positive therapy is anything that we might do around us to give us any passive positive energy. Like it just gives you positive energy passively. Like anything, like the examples that we can take is religious artifacts. Like all of us, we around us, anywhere if you look around, we will have these religious artifacts. So what does that do to us? It just gives us positive energy passively, right? We would have our family pictures in their homes. We would do decoration in our homes, right? The lucky penny we might want to carry in our wallets. Uh, 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 and the lucky pen we used to take in our exams, that when I'm going to take this pen, I'll score good marks and I'll get the best answers, right? So all these things that we already have in our lives, we just have to identify them. Like we are actually doing it as passive positive therapy around us. Okay, I'll give you a recent example for this. Most of you must have seen the movie Castaway. In Castaway, there was this ball. This the guy just got when the ship got wrecked by the island. So he just named it Wilson. So what us humans, we have this intrinsic quality of creating passive positivity around us. I'll come back to it, how passive positive therapy can help us taking care of anxiety and depression. So uh, uh, how can we do it? In landscaping, we do landscaping. There's architecture. There's anything that even the seats, the seats you're sitting on, like the material that has been used, it has been used by someone to give you passive positive therapy. Like passively it give you positive therapy. Okay, how did I come to this? Being a doctor, fine. 2002 graduate, came here, drove a taxi. Like initially there was gas station and shoe store. Drove a truck, had a big accident in truck, right? In 2008, 1 month after my marriage, I had this big accident, double slip disc. So the first thought that came into my mind was, think positive to generate happiness. Okay, then I got this son of mine. I named him after my dad. So uske liye then I made these lohe Quranis, like something that we, in our religion, we just give it to people in our happiness. Whenever someone comes to us, we distribute these. Whenever someone goes to us, we distribute these. So I distributed this. Now I got like 20,000 of these made. I went to Pakistan. I go like, okay, fine, buddy, give me like, if I want it for 10 rupees each, how much do I need to get printed? He said 20,000. Okay, fine. I got 20,000 of these. I bought them to Canada. I go like, now how am I going to distribute it? Initially, I used a lot of people. Like I would take them to mosques and people would deliver it. But then what I did, I took these boxes from the convenience stores, and I just put a scale on it, and the hanger knob that you might use. So I just hung this thing on top of it and left few in the box. And I just went to a store and I just put it there. Nothing happened. It didn't go away. My mom, she actually gave me an idea. She was like, why don't you write free on it? So as I wrote free on it, boom, next day box was empty. I found like 36 different places that I just put this box on, and it just boom went away. The point is not that what went away. The point is that positive therapy was being done passively. I wasn't there. There were these things that people use to get their religious gratification. They all got it from there. With I'm not being present there. So positive therapy was done to them passively. Okay, I did that. I was blocked in one community only. So I go like, okay, fine. Why shouldn't I grow it? I came up with this name, Book of Positivity. Then I go like, okay, fine. People are interested in these good words: love, happiness, joy, comfort, inspiration, peace. So I printed these chits out. Then I would just make a whole tray of these flags with all these chits on it, and I would just put it in different occasions, like different functions. So there are flags over there that has smile, happiness written on it, and on top I had written like, okay, fine. If you take smile, please write something about it on a journal that was just beside it. So so what was happening there? Over there, I was just sitting on the side, and people were just getting love that they absolutely admire, happiness, smile, peace, basic stuff. We don't focus on it, basic stuff that people are looking for. And they were actually writing about it. So they were doing the whole positive therapy with me sitting on the side. Passively, this was done to them. Okay, now, why passive? Why are we talking about passive in medicine? Because everything has to be very active. We have to make money on it, and like yardly. Yeah, why passive? There's a branch called a passive physiotherapy. Okay, what happens in that is like the heat waves that we give to the injured muscles to just increase the angle of movement, like motion of the muscle. So those all part, and even when we have a fracture, we put a cast on it. Okay, and we just let it heal on itself. So that's also part of passive physiotherapy. So if we have passive physiotherapy, then why not passive positive therapy? That, like, one good example of it could be like, if you just imagine like people living in old cave times, like the cavemen, what would they do? The stones they would use in the caves, they would just move it around to get proper sunlight or proper wind from the outside. Or they might plant some beautiful flowers right outside the entrance of their cave. Why would we as human beings do it? We have this intrinsic quality of creating positivity around us. Everything that we see around us, and recently what we have seen in last decade, I think so in whole North America, there is more of usage of these words like love, happiness, smile. Because if you look at the bigger picture, yes, we are stuck in our own cocoons, and we don't want to look at the bigger picture. There is climatic change. People are feeling the pressure of it. So like when I would go out, when I was driving a taxi, I would go out and about, and I would just observe people, and they're gloomy. So even in this experiment, what I did was, like, I would just take a chits of, I have like 100,000 chits of these. So I would just go and put them on the floor and watch people react to it. Some people might just jump over it. Once this guy, he just picked up love and he just took it close to his heart and he just walked away. Or when I would just be walking on the street, it was really hard. Like I must have met like 30, 40,000 people. People I don't even know. I would just walk on the street. It was really hard. Now, the point in that was I was just trying to get to this passive positive therapy, because even when I'm carrying this tray with love, happiness, joy, comfort written on it, fine, this person in front of me, I might talk to that person. Okay, fine. Would you want to take some love or happiness? But the other people, they're just looking at it, and it just brings that split second of smile on their face. Like, people would pay money for happiness. They would get it for free. That was my way of taking this ahead. Okay, how can passive positive therapy help us? The most important thing, how could passive positive therapy help us is, we first have to identify it. As doctors, we could tell it to our patients. Like, it's actually, you're actually empowering the patients. What I would see initially, like, like we would get those expensive chains written hope on it, or love on it, or smile on it. Why should it just be to buy, or like, people should buy it? That's why I made these, and I just spread it in random people, like common people. A lot of people I meet sometimes, they go like, oh buddy, I still have that smile in my home, and whenever I see it, it makes me smile. So it's kind of passive positive therapy. That's why I call it a social experiment of passive positive therapy. It's not only that, like, with these, I would give these out during my Uber rides, being a doctor. I would just give people out this love, happiness, joy, and I would just make them write their definition of love. Like, what is love for you? So that is coming out as a book. Again, how can this help us in because a lot of mortality rates, like if a person is positive, I'm sure mortality rates would go down considerably, right? If you're happy, like, you can embrace death with happiness, or you could be really calm about stuff. You could face a lot of your troubles very calmly, if you can just have this ambience around yourself. Listening to music is part of passive positive therapy. You go to different arcades. There is music playing on the side. What is it actually doing? It's making us feel comfortable about ourselves, and it makes us buy more, and we are relaxed. We spend more. So it's all around us. Passive positive therapy is all around us. It's just, if we could just start identifying it and promoting it more, like all the patients you have, troubles they're having, just tell them to, whatever you like. Okay, very interesting examples that I recently got of passive positive therapy from our own DOW group, where when Naseem showed all his books that he had. That's his passive positive therapy. Salman, he showed all the cars he had in his driveway. That was his passive positive therapy. Farhan, he showed all the plants he was growing in his balcony. Yeah, his passive positive therapy. And Shazad, like his certificates on the wall. That was the best example of passive positive therapy. Like, we created it around us. It's just if you could just differentiate it into an active positive therapy, and then there's passive positive therapy, where active positive therapy is where you go to a doctor, you go through a session, or you take medications. And then there's passive form of positive therapy, that you just have, like I'm sure a lot of you might have, you guys are living away from your family. A lot of you might have in your wallet, so very close to you, your mother or your father's picture, or your best buddy's picture with you. What is it doing to you? It's just giving you positive therapy passively. So that's what we could do to identify and empower the basic man, like all the patients of yours. These are the few things that you could do, and you could create your own positivity. That's where I would end. And it's really simple. It's just, you just have to, like Einstein, he saw that ant climbing up. It's just that third time the ant climbed up. It was just try and try again. And these are very simple things that you just have to identify.
Mansoor, thank you very much. Excellent talk, very enlightening. I'm sure people will have questions, so I will open to the floor. If anyone has any questions, you can raise hands as well in the Zoom function on the right hand side of your screen, or just shout. Sorry, let me just unmute.
Yes, please unlock us, unmute us.
Yeah, I've just unmuted all of you. Any questions for Shehzad or Mansoor? Okay, I think whilst the audience is still thinking of question, Shehzad, I was just going to ask you about the DTI. So the DTI, exactly what does it do? It tells you kind of what neurons are functioning, what are still at risk, or is it like a functional measure, or what exactly it is?
So diffusion tensor imaging is a software-based MRI modality wherein you can see the long tracks going from the cortex down through the basal ganglia to the brainstem. And it can track all the 3 different types of tracks. So the longitudinal tracks, transverse tracks, horizontal tracks, interconnecting tracks. And the MRI, what it does, it creates a 3-dimensional reconstruction of the same tracks, and then uses the tumor, the information about the tumor in relation to these tracks. So basically, you're looking at the 3-dimensional view of the tumor and its relationship with the tracks. Now, there are several types of tumors. Extra-axial tumors only displace the tracks without involving them. The intra-axial tumors involve the tracks, and whenever a white matter tract is involved, any attempt at dissection of that tumor would actually worsen patient's neurology.
Yeah.
So what this information actually allows us to do is to be able to decide which parts of the tumor that we're not going to dissect, which parts of the tumor we can safely dissect without worsening the patient's neurology.
I see.
It's actually an even better technology is to do the operation awake and then monitor these tracks by intraoperative stimulation. So what we do, and we don't do that quite often because it takes a very long time to perform. It requires a big team to do it. We need neurologists, we need neurophysiologists, and lots of other people. So we activate these tracks intraoperatively and then see what function these tracks represent. So it's basically functional confirmation of DTI data. And so that gives you 100% accuracy in terms of which parts of the brain to dissect and which not to dissect.
Okay. I've got. Thank you very much, Shehzad, for an excellent presentation. I've got a couple of questions for you. So, and I promise you these are not stupid questions this time. So, the first question is actually about you oversee a large medical surgical department. I think you're probably a clinical service lead. What do you think of the other specialties? I mean, do they have the same desire to kind of actually develop their sort of ORs the way you have developed your neurosurgical OR? That's the first question. The second question is actually where do you see artificial intelligence actually going in the way forward? Would they be replacing us as humans to kind of actually perform such complex procedures?
Okay. In response to your first question, are other specialties also looking to develop their ORs? So a set-off is online. Well, actually, our general surgeons do a lot of stuff in hybrid ORs. And so these are ORs which have a facility for endoscopic work, minimal invasive work, and open work at the same time. And then our vascular surgeons do a lot of work in hybrid ORs where you can do angiography, and minimal invasive work, as well as open work. So these are also very complex ORs. Neurosurgical OR is a cut above. And I don't mean to say that it's I mean, it's just the nature of the specialty. Mm-hmm. There are editorials where the modern neurosurgical OR has been compared to the cockpit of a spacecraft, actually. Now, it can only, and this is based on evidence, it can only ensure that you do a good job with the surgery. I mean, the reason for my presentation was that, unfortunately, that does not always mean that you do a good job for the patient. So if my post-op scan looks wonderful, or my post-op X-ray shows fantastic screw placements, it does not necessarily mean that my patient is also going to do well.
Okay.
So, and in response to the second question, the role of artificial intelligence. So artificial intelligence or machine learning, in the role at the moment is only in terms of diagnostics and prognostication. So we can use machine learning softwares to diagnose complex tumors, complex pathologies, and also to pick up patterns and predict what's going to happen next. And that's why a lot of it, the work that the Harvard people are doing on AI and MLS is basically oncology and diagnostics. Even now, well, as of yet, AI and MLS has had no role in determining, in assisting surgical interventions.
Okay.
Maz has a question.
Okay, thank you very much.
If we have robots, the robots will actually need a person behind it to control it.
Yeah, I can watch for the robots. Yeah, we do have a Da Vinci. We use it for urology, for robotic prostatectomy and nephrectomies. But yeah, you do need a very skilled surgeon using the robot to make sure it goes according. Having said that, research has also shown that there's no difference in recovery time periods using robot compared to a conventional for a prostatectomy.
Maz has a question. Maz, go ahead.
Thank you, Shahzad. Both fascinating and intriguing. My question is, you showed a slide, Pakistan's health expenditure and GDP. And my first question, what is the source of this and do you know this latest trend, I would be keen if you've got anything, details regarding the data to share with us, Thank you.
Naseem, can you repeat the question, please? I had a disconnection in the middle.
Naseem, can you repeat it, please?
Maz, repeat your question.
Yeah. Question is about to Shahzad is, you showed a slide, the Pakistan's expenditure and the GDP. So my question is, what is the source of that the data, and also do you think that graph is further going down? In the last 3-4 years.
Shahzad, you got it?
Yes. So this slide is taken from the Sindh Health Commission's economic survey, and one of the things that you would all be interested to know is that Pakistan's health outcomes, Pakistan's health expenditure, Pakistan's health direction is all very carefully audited and presented, and the entire data is available on the websites. And that's why it makes it easier for healthcare professionals to make a case in new government in which way we are heading. Now, the problem is probably not the funding that is available for healthcare professionals or for the healthcare industry. The problem is the utilization of the funds. Suhail mentioned Da Vinci robots, and Suhail mentioned that they don't improve outcomes. But instead of deferring to him on some technical grounds, I'm just going to mention that there are at least 10 Da Vinci robots in government hospitals in Pakistan, and not a single Da Vinci robot in any private hospital in the country. And these robots have been bought at 4 times the cost that they are available in Europe and North America. And none of these hospitals, and I can say that with certainty, none of these hospitals have actually renewed their yearly contracts with the Da Vinci company, so the robots no longer work. So that's where our health expenditure, budget is going.
Thank you very much.
Mazhar, I have a question for you. Who is kind of bearing all the costs for the philanthropy work that you're doing? Is it supported by some NGO in Canada, or do you self-fund it?
All that I've done is all self-funding. Everything that I've done up till now, it's all been done by me. I've just been smart about it. I've not used a lot of expensive stuff. I would just use small things like these papers. They don't cost a lot. I would like to show you something that's coming for the book, and this is the all flags of the world. That's gonna be on the
I can spot
books
Pakistan's
page.
flag.
So yeah, Pakistan's flag is with India.
Right at the front.
They're together too. So this is also, you know, in a way, when a person would have this book in their shelf, they have all the world together on one page and with peace on it. So that's the whole concept, passive positive therapy. If the world could understand it, I think a lot of like, fine, I might be the one who discovered it, or who found it out. But there's so much work that could be done on it in future. I'm sure a lot of scientists could just get involved. And first thing that I'm doing, like the next thing that I'll be doing is, first this book is coming out, then I'm bringing out the app. And the way I'm building the app, that's also kind of passive positive therapy. Yes, it has been delayed. I'm all doing it all on my own. So however I'm doing it, I think so that's the track I'm taking. And hopefully, one thing that I would ask from all of you is, please, in your all practices, try to teach your patients about it. Just see the reactions they would have. In your waiting room, put some nice words over there, happiness, put some love over there. You know, like, do this stuff. Half of the patient would be cured before they'll come to see you. Try.
Yes, thank you. Mazhar, actually, I just wanted to ask you a question. You know, you talked about listening to music and listening to kind of actually, you know, some songs and things like that. Is there been any research in the West about the influence of listening or reciting Holy Quran on positive passive therapy? Because obviously we as Muslims know how much Quran and listening to Quran can actually influence. But what about the West? Is there any research? Have you come across something like this?
I have not actually come across anything of that sort. So I would not comment on it, but presumably that's the best thing you could do. See, my project, what I've done is, a lot of people have tried to put it on one religion. That's the worst thing that I've faced doing it in a Canadian white country, right? Because everyone would just relate to, like, even our own people, they would come to me, they would go like, oh, usme hadith honi chahiye, you know, like there should be some religious ayats in there. But my focus is not like, let's not block it to one part of the society.
True.
That's why I made these up. I'm making these flags up, going out there, giving people smiles, right? So it's everywhere. And more than our religion, our own sect of the society, the other people, like their whole life is based on passive positive therapy. Everything they do is passive positive therapy. Like, how should be the size of the room, north side, east side, west side. This is all part of passive positive therapy. We've all been doing it forever. No one has ever tried to name it. Like, once we name it, we empower the things that we are doing around us. Then, you know, there's this personal gratification that a person could have. See, yeah, I've already done passive positive therapy around you. So empowering the people, my friend.
Sorry, Mansoor, something actually I've learned over the years, basically. So when you've got a bad day, you've got a crisis on the wards, you've got actually busy sort of clinic running late. If you say something positive to someone, actually, that actually evokes some response, a positive response, and that creates a positive atmosphere within that actually clinic or within that ward. So I always start with something positive, honestly, whether, you know, I mean it or not, but positivity begets positivity, I would say.
Ripple effect.
Honestly.
That's the whole point. Like all these that I've given out, I don't even know the people I met. Initially, when I started, I would get scared of those 6 foot high people. I'm a tiny little guy. You know, like I could get smacked anywhere on the street. But but initially it was scary. But then with time, I just grew in strength, and I ended up giving out more than 40,000-50,000 of these chits, like thousands of these flags. I actually asked Canada that give me a list of any Canadian who has given out more Canadian flags than me. They have no list. There is not a single person who's given out Canadian flags.
Wow.
So we should be expecting Canadian flags at London 2020 then.
Buddy, I got the whole world flags here now. On the book, it's going to be all world's flag. Like, and hopefully one day I could get it into the medical books, and you know, we could all empower the basic person, the people who run the whole world.
Thank you.
Okay, very good, excellent. I think
I have a question, if you don't mind.
Can I ask
Mashood's got a question. Mashood's got a question.
For Mazhar.
Okay, we'll take one last question. Go ahead.
Okay.
Yeah.
So Mazhar, what my question is, when I see my patient in my office, so I see a lot of depressed patient. So my question to you, in your experience, if you have, do you use this therapy just for like, okay, we are sometime in our life are a little bit on downside, not really true depressed, but a little bit on down. Everybody should have in their life sometime, somewhere. Okay. So do you think this therapy, what you telling us, it's work for those incidents, or it's work for true depressed people who come in my office and cry for 5 minutes and they say, okay, Sajad, you have to tell me, okay, what I can do in my life. I don't have a wife or whatever, vice versa. I don't take my medication and blah, blah, blah. So that's my question. Do you think these therapy, or what are you telling us, it's only working for the people who have like minimal depression or slight depression, you can say, rather than the true depression, which we usually treated with the medication? Go ahead.
Okay, with the medication, the people who are really terminally ill, you need the medication, you need the therapy. I could suggest one thing that you could do is in your clinic, just put the word of love, just put a word of happiness, or put word of peace, time. Everyone is looking for time. Just put time over there. And when your patient comes in, just ask the patient if you can just write 4 things about what you love or what you have done in your home, like in your surrounding, like the comfortable chair you got. You love it so much now because you're so comfortable in it. So just by identifying, like just by telling them that, okay, fine, see, you might be depressed, you might be ready to kill yourself, but buddy, you have that chair that's making you feel happy about yourself. So, you know, these are very basic things that we do. If we can just cut it down, simplify it. Like in positivity, I see everyone working with all the yardly, yeah. Buddy, perfection is an illusion. There is no perfection. Okay. So, like a lot of people, the best part, what has happened by me doing all this experiment is a lot of people that meet me, they're certainly enlightened. Like they meet me and they're like, whoa, but I might be the most depressed person at that moment. Because yeah, like the doctors, like fine, I might be treating a diabetic patient and I might be giving him insulin. It doesn't mean that I have diabetes too, right? So, but it's just about letting your patients understand that they already have it. Just ask them if they have any of their family pictures around them, or you know, naming it and empowering the patient.
Got it.
Very good. Excellent, Mansoor.
Naseem, please, can I ask Shahzad and Mazhar a question, please?
Yeah, okay.
Okay,
Yeah.
go ahead.
For Mazhar, so what you're saying is your therapy basically works on seasonal depression, but not clinical depression, right? For clinical depression, you still suggest we take medication and therapies. And what you're talking about is basically day-to-day depressive episodes or seasonal affective disorders and stuff, but not clinical depression, right? Okay, cool.
Kind of.
My second question for Shahzad was, regarding your awesome surgery regarding the glioblastoma and the technology you used, you said the outcome was still very minimal. So could you elaborate on that as to what happened? Was it the patient that suffered, or was it the surgery? Because you did say the surgery was awesome and it improved the outcome clinically, but what happened to the patients?
So the data that we have for glioblastoma, I'm sorry, can you hear me? Yeah, so the longitudinal data that we have for GBMs or glioblastoma multiformes is that with no treatment, from the time of diagnosis, if you don't treat a patient with GBM, the patient dies in 4 weeks. Now, if you only treat them with steroids, they may live up to 3 months. And if you treat them with steroids and chemotherapy, you can extend their survival to up to 5 months.
And what is your take on CBM?
I'm sorry, I'm not finished yet. Sorry, sir. So now, the way surgery makes a difference is that if you're able to excise the entire tumor, so achieve a gross total resection, which means essentially taking out the entire tumor that's visible on the MRI scan, you can extend the progression-free survival and overall survival to up to 2 years. But you cannot cure the disease.
Okay.
So yes, there is this clinical advantage, but you still cannot cure the disease. Now, without all of the equipment that I just mentioned, you're still able to achieve maybe not 100% excision, but maybe 80% dissection. And with 80% dissection, the outcome is still only. So what I'm trying to say is, with all the machinery I talked about, you can only extend the outcome by maybe a few weeks and not more than that.
Okay. And what's happening with the therapy in Pakistan regarding CBM, the clinical marijuana? Because apparently they've authorized in UK the use of CBM for some sort of brain tumors, because apparently it helps with the symptoms.
It actually works for pediatric brain tumors. Its role is not clear in adult brain tumors, and so far the data is still experimental. But in Pakistan, it's still not being prescribed. We can get it off label, but we can't prescribe it. Can I just make a comment on Mazhar's presentation?
Yes, please go ahead.
Mazhar, thank you very much. We're all very proud of what you're doing. But it might be better to actually reinforce your message on the basis of science and evidence, because there's a lot of evidence, there's a lot of science behind it, there's a lot of evidence to support that visual, auditory, sensory perceptions actually improve mood and elevate hormone levels. And the data is not new. We've known this for decades. Our psychology, psychiatry friends can maybe talk further about it. But whatever you're doing is proven by science, and it might actually help process your message in a clearer way if you can support it with the existing science on it.
It might even help you get funding, man.
Oh, yes.
Yeah.
Yes, like I think so. I'm taking it to that point where see, when you're bringing something new up, it's not easy. I've been called cuckoo. I've been called all that stuff. So initially, I'm just trying to get the word out. Then yes, that's what I plan to do. I want to take it to a university and give it to the UTM here, and all the young kids could create so much wonders of it. All these big websites, Facebook, Uber, and all that was just created by kids over here. And with the app that I've built behind it, hopefully, let's see. Trying my best. But the best part is those 10 people that I meet every day, unko jo love happiness deta ho na, that the split second of happiness that you get. Try doing it yourself too. You know, like just write love on 10 pages and try to give it to 10 people and see the effect.
Mansoor, I love what you do, man. I've been watching your videos, you know, the everyday videos, but I don't know why you stopped doing that. You should start doing that again, man.
Definitely.
Okay,
Yeah,
thank you.
Okay,
been,
I think.
been a big fan since one.
Yeah.
Okay, before we finish today's session, I've got kind of some very quick announcement to make about the future sessions. So I've just been informed by Mansoor, who's doing some really good hard work behind the scenes. In September, we have kind of provisionally confirmed Kashif Shazli and Samia Ahmed and maybe Waqas or for incidental adenomas, etc. And Kashif doing some radiology session. October, we are trying to get Hasnan, Hasnan is confirmed, and also Imranul Haq for some A&E talk. November, we are trying to get Sajid. Hello, Sajid. Hello there.
Hello, Sajid.
We are trying to get Sajid for metabolic syndromes and
Sajid.
for neurology. And December, we are going to have some quiz, inshallah. And for January, we have Subela and Sadaf, hopefully. So please get in touch with Mansoor if you want to present. Some of these speakers have confirmed, some of them have not confirmed yet. So please get in touch with Mansoor, and we'll see you next month, hopefully.
Okay, inshallah. Thank you very much. Thanks, Naseem. Thanks, Shazad, and Mansoor once again. Thank you. Have a good evening.
Allah
Hafiz, guys.
Allah Hafiz.
Nice meeting you all after a long time.
Oh yes, after a long time. Love you all. 50 years.
And thank you, Mashood, for coming. Mashood, could you just send me your email?
Awesome, Shazad. Nice seeing you too.
For the certificate. Thank you.
Please send your emails to Mansoor for CPD certificates.
Yes, thank you. Allah Hafiz. Allah.
Please share